Hello, my name is Jay Bhatt. I am Senior Vice President and Chief Medical Officer of the American Hospital Association and President of the Health Research Educational Trust. I'm joined by Dr. Rishi Manchanda, and he has real wealth of experience and knowledge, and so together we look forward to sharing some of that with you in conversation.
I think we'll just kick it off today, this conversation, Jay, by asking why is AHA itself creating this curriculum, the Social Determinants of Health curriculum, and who is it intended for?
The AHA's vision is a society of healthy communities where each individual has their highest potential for health. And so we asked the question, how do we know that we're making progress on that vision towards the picture of advancing health in America? And so we have 5 commitments that were discussed by the members all around this country. And it was a fascinating experience to see organically the conversation emerge about what are the values, those commitments that help us know that we're making progress towards the vision. And they came up with 5. 1, access. Access to affordable, equitable behavioral health and social services. 2, value, delivering the care that brings value to people's lives, the best care. 3, well-being. So looking beyond the hospital, beyond the 4 walls and redefining the H and working with community partners to help drive prevention, chronic disease management, and health upstream. And diversity, engaging a diversity of individuals, families, and community partners in health. So really that the care team and the leadership and the governance reflect the diversity of communities the organizations serve. And then coordination, using data, teams, and technology to seamlessly coordinate care. And we had a national conversation in March earlier this year across the 9 regions of the country talking exactly about this issue. And one of the things that came up in that conversation is we need help. And they're turning to the AHA for help, which is exciting.
I'm wondering if you can speak to what this means specifically for physicians. What does this mean for physicians, executives, those on the front lines and those in administration?
And so for me personally, as a primary care doctor in an underserved community on the northwest side of Chicago, I see firsthand the challenges that clinicians face in thinking about the social determinants of health. And so there are ways that we can address it given the community partners that we can develop. Hospitals and health systems have built these partnerships over a number of years, but it's applying a systematic approach to understanding what might be driving a health outcome driven by behavior or the transportation challenges that it takes to get to care or food insecurity. I know that you've done some work looking at the issue of diabetes and food insecurity, and that folks, when they're late in a month who don't have the right food end up taking medication in a way that's not appropriate. Or when we see someone come in for challenges with housing, we have the skills from a history and physical standpoint to ask the questions. So if someone has a headache and they've got imaging, but actually it's where they live that's causing the symptoms, and so the diagnosis of allergic rhinitis versus something else helps you direct care and support to move someone from their environment to a better environment and give them symptomatic treatment. So I think that part of what we're trying to do is help clinicians have a framework and an approach and tools to screen and then understand how they can use their skills as clinicians combined with those screening question answers, and then work with the health system and the community partners to achieve health for these individuals.
Let's dig a little deeper, if it's okay, and speak about why this matters from the perspective of joy. What it means for resiliency, what it means for why we get up in the morning as doctors and as other clinician leaders in America's hospitals. What does joy at work have to do with social determinants from your perspective?
We want to make it easier for clinicians to do the right thing and do the things that they have trained to do. And when we can't feel like we're making progress in the care of patients and families, and then there's other things that get in the way, like, gosh darn it, I thought I treated that asthma perfectly right, yet they're ending up back in the emergency room or in my office. It's because they're in the conditions that make them sick. And so that level of sort of repeated experiences creates a sense of I'm not doing enough, or disconnects clinicians from their commitment and their purpose. And so by helping clinicians address the social determinants of health, again, not alone, but with partners, but at least be able to recognize it and then say, we might think about this care plan differently, and then see the results of that different action, allows clinicians to be connected and meaningfully to the work they do, because we all want to see, patients get better. We want to see families be healthy and happy, and we want to see communities be places and beacons of health. Addressing the issue of social determinants of health by helping people not be readmitted, by helping them be healthier in their homes, by helping them get the care they need, that they don't disrupt their daily lives to come get care. That all has an impact on affordability. And so if we can avoid high-cost trips to the ER, that is not just financial savings, but it has an impact on the suffering and the emotional well-being of not only individuals and families, but on the emotional well-being of caregivers as well.
Well, a big amen to that, Jay, for sure. I can't underscore enough the connection between emotional well-being, to your point, joy, just the ability to feel a sense of meaning and purpose when we get up in the morning as clinicians and working in our hospitals, and this question of how to address the social determinants. As you know, the social determinants, everybody's talking about it these days. It can start to sound a little airy, a little jargony, and the more we can ground this in the connection to everything you're mentioning, from the 5 commitments, affordability, the experience of patients, but fundamentally about why it matters to us, our sense of meaning and purpose, the more I think we can feel a sense of connection and really understand why it matters. One of the other things, Jay, I want to ask you about in terms of why it matters, to get folks really engaged into this conversation, into the series of conversations we're going to have, is demonstrating that this is possible, right? Sharing stories is such a fundamental part of this. And I'm wondering, I know you have a lot of experience, the AHA itself has a lot of experience working with member hospitals that are moving upstream, that are addressing social determinants of health. And I'm wondering if you can share some of those stories as examples of the ways in which different hospitals are figuring this out, showing that it's possible.
One, a health system in the southeast part of the country that started engaging in this notion of coopetition, right? 2 fierce competitors in a market that actually, instead of competing, came together because the central problem they saw was that patients, a large proportion of their patients, were shuttling between both emergency rooms. And so when you look at that group of individuals and that data, you say, why is that happening? But we know that we want them to be healthy. We know that we want to support them as a community. So what do we need to understand in order to do that? And so what they did is they worked with the Mecklenburg County Health Department, and they identified 6 zip codes in which the large proportion of those patients were emerging from, and then went and visited them with their care teams and had questions and conversations to understand what was bothering these patients and what was making it difficult for them to achieve health. And so some of it was food insecurity, some of it was transportation, some of it was jobs, because then the health was lower on their list. But the other thing they understood was that there wasn't an easy access point to care in that 6 zip code area. And so what they were able to do was together say, all right, we're not only going to have a plan to try to help address the social determinants of health they have, from social isolation to food insecurity to transportation to economic opportunity, but we're also going to put an access point there with jointly teamed by both organizations so that we collectively address the issue. And that resonated really with the organizations and the community there. Another is this notion of taking what we already know how to do well, quality improvement, and applying it systematically to the issue of social determinants of health. So an organization in the Midwest said, hey, what is the one thing that we want to start with that's of high impact and affecting our community? And it was hunger. And so they looked at the notion of hunger and food insecurity, because pregnant women and children that are experiencing hunger, that aren't food insecure, have long-lasting consequences. We know the early childhood experiences and early childhood development has a long impact, a lasting impact on health. And so they systematically screen for food insecurity for their patients. And then we're able to identify a set of patients who screened positive and then referred those to a food pharmacy. And then once they were able to do that and their clinicians were able to make those assessments and make the referrals with the community partner, they saw a decline in readmissions by 50%. They saw an increase in primary care uptake by 4%. They saw a community reimagining and transforming to health just by that one intervention. And now, they've progressed to continue to improve that effort and be an anchor institution for the health of a community, and working on other issues related to social determinants. So violence is another big issue, and so there are organizations all across this country that are engaged in our Hospitals Against Violence initiative and are trying to provide support upstream to try to provide clinicians with the tools to screen and intervene early, and this includes those who are victims of violence and trauma, and so trauma and informed care across a longitudinal span. And then I would say involving people and families in the work of community health is really important. So we know another organization and system that has done work of community visioning, where they invited the community to help share what their needs were, rather than saying, here's what the community health needs assessment tells us what our needs are. And so rather than thinking that it was transportation or food insecurity identified by some of the data, it was the people and the community that said, no, it's economic security and jobs were really important. And so the 3 hospitals in that jurisdiction came together and invested together in 14 small businesses that not only gave folks economic opportunity, but then they also did financial counseling and prevention teaching, and together we're able to not only grow those economic engines, but improve the health outcomes of that community. And now it's one of the top 10 communities in Richmond that's fastest rising in terms of health in the country.
Rishi, I know you've had deep experience in this, so I'd love to hear what you think social determinants of health means and why it matters, and a few examples from your own journey as a clinician.
There was this kind of feeling a few years ago that talking about social determinants of health was choosing between providing care or addressing social determinants. It was an either or. It's actually a false debate, right? I think, as your examples rightly point out, and as I've learned, and as Health Begins certainly is learning every day, this is not a false choice. It's actually a way to do both. Community partnerships improve access, improve value, and can improve coordination. And they can do so specifically when we focus them on social determinants. So advancing the 5 commitments for the AHA is something that we're seeing happen every day by virtue of moving upstream. Just knowing that it's possible makes it that much more engaging. It allows us to lean in, learn from examples, realize that this change is possible, and that's fundamentally important in our experience. So I'll give you a couple other examples of the work that we've seen happen. That's been, to underscore your word, exciting for us. I'm effusive about the work that's happening across the country right now, because it touches on everything that we've always cared about. And that finally we can have a clinical system that's able to partner up with public health and partner up with the social sector in a way that is more seamless than ever. It's not there yet. I don't want to be Pollyannish about it, but we're finally moving towards that glimpse of what I think we all wanted to do. One example of what that looks like is work that we've done in a health system here in California. Large public hospital system, large clinic, ambulatory clinic practice around it. And what they found was a similar set of partnerships that they had with community organizations around food. Their executives, their leaders, their medical directors knew that there were these resources in the community, food banks, et cetera. They knew their patients needed them, especially their diabetic patients. What they found was that they didn't really see beyond that kind of knowledge a lot of traction, right? The clinicians weren't referring, the care teams weren't really knowledgeable or confident about how to talk to somebody who has been screened for food insecurity. And so why screen if you don't know what to say? there was a sense of, the partnerships were there, but they were kind of in theory. There were handshake agreements between the executives, but not really something that was sewn into the DNA of the day-to-day practice. So what we did with this hospital system was to really work with them to translate this theory into practice, translate these partnerships into operations, so that the care teams, the folks who know quality improvement, could leverage those assets, leverage that infrastructure, right? Their Lean Six Sigma training and their quality improvement committees and their medical director meetings, and start saying, well, how do we apply the rigor that we already apply in other work, reducing hospital infections or improving access to care, reducing no-show rates? How do we take that same know-how that got us to tackle those problems and now apply it to this question of getting more food to those who need it? What was remarkable in this process, that we call it upstream quality improvement, upstream QI, was exactly what you underscored as well in the examples you shared, Jay. Quality improvement, the tools, the assets that we already know are out there that we use every day, when we apply it to upstream issues, can achieve remarkable results. Within 4 months, this hospital system achieved a 12-fold increase in the number of referrals that they were making to local food banks. And they were doing it for patients who needed it the most, especially diabetic patients. They saw a tripling of referrals for diabetics who needed access to a clinical pharmacist because their A1C was uncontrolled, above 9. They saw a 95% screening rate achieved. The baseline was 0. They hadn't even collected the stat. And then within 4 months in this quality improvement campaign, they got to 95% screening for all of their target population.
It's great.
Remarkable. These numbers, mean the more important things, which is that the people behind them, the clinicians, the care teams, the change makers, right? They were all participating in a transformation in the way their practice could now address social determinants and improve care. Well, Jay, thank you so much for today's conversation. It's really been a privilege to be talking with you, to be learning more about what AHA is doing, and for Health Begins itself, just to be part of this conversation and help advance this going forward. This drum roll is getting louder and it's getting more steady. This drum roll towards a new kind of future that allows us to advance health in America by moving upstream, by addressing social determinants, and it's truly exciting to be part of that. So
Let's go upstream.
Let's do it. Thanks, everybody. And
thanks so much.
Thanks, everybody, for listening in. Talk to you guys soon.